Thanks so much, Carrie, and thanks so much for those of you who are attending live and those of you who are watching the recording. On behalf of pediatricians, families, and communities across the country, I want to take this opportunity to thank you for all you are doing to support families, children, and your communities through these uncertain times. And also thank you for taking the time out of your busy day to listen to this important topic. And I'll try to do my best to make sure that this is time well spent. So I have to have a disclaimer here because I'm not a lawyer, and I want to make sure that everyone who's listening and viewing understands that the information doesn't constitute legal advice. This is really my interpretation of spending over a year deep in the weeds of the 21st Century Cures Act, and wanting to share my knowledge and expertise and insight from those multiple conversations that I've been having over the past years. But it is your responsibility to make sure that you work with your system and your advisors so you understand how your practice will implement the 21st Century Cures Act for your patients and your practice team. My learning objectives for today are to really look at what the 21st Century Cures Act is and what information blocking means, how this will affect your pediatric practices and your patients, and what your practice needs to in order to be prepared, and some resources to support you in that work. There are other aspects of the 21st Century Cures Act that we will not be delving into detail about today. One of them you may be hearing about in the news recently is about price transparency and making sure that patients can actually see what their healthcare out-of-pocket costs will look like. There is also a provision in the 21st Century Cures Act for making sure that there is a voluntary pediatric EHR certification, which supports pediatric practices and having health IT. We will not be talking about that in detail here either. So I like to start with some definitions, and I'm not going to go through these, but you will get the slides. Those are hyperlinks to take you to important sort of overviews of what all of this means, because there's some technical language that when you read through everything, you're going to wonder, some of you are going to wonder what the heck we're talking about. But to start at the top, all of this is driven by HHS, which is the Department of Health and Human Services. Underneath HHS sits the Office of the National Coordinator. They're the people who are supposed to be writing and suggesting laws and changes so that health IT advances across the country. But the OIG, which is the Office of the Inspector General, is actually the people who enforce that. EHI is electronically stored personal health information. We got used to PHI as far as HIPAA. But we'll go through some of these as we do the slides. I wanted you to have the resources so that you could look and learn more at your leisure. So at the outset, an overview, what is this 21st Century Cures Act? And it really was started by a movement in the government to make sure that patients were empowered with their health information using technology. Not, I need to get my 47-page printed out record from and call a week ahead to get it in order to go to a specialist. But it really is putting, the move was to put patients in charge of their health records. And there's an undercurrent theme to try to move towards a value-based payment system. This is just one of the technology pieces to get there, but it's really about patients needing power in their healthcare so they can make informed decisions. And you've heard me say in other venues that information is power. The impetus behind this was to give patients their information so they are empowered. And the overview includes putting the patient first in the health technology. And again, you're going to see this transparency into cost and outcomes of care when you read through some of the links. That's not really the focus here, but part of this was how do we get ahead of the incredible spend that we have in America for healthcare, and how do patients and families get empowered to not only see, have their information, but know how much it costs to get care. Everything in our world is moving to modern smartphone apps, and this is a movement to try to move in that direction itself. And that doesn't mean you're charting your visit on a smartphone, but this is a family or a patient has an app on a smartphone that helps them manage and share data or connect to an app that helps them manage their health conditions better. And it's really looking at where everything else is going in information, and health IT has just been far behind, and that's at the app economy. But the Congress really wanted to, and how they got this through Congress was to say that we start unraveling sort of the opaque schemes, both about care that's delivered and price behind the scenes, and make it pull back the cover so patients and others can see exactly what's happening. Many of these slides are taken from the healthit.gov and the ONC website, and there are actually 3 groups of people who are impacted by the 21st Century Cures Act: patients, clinicians, and health IT developers. Most of you don't really care about the health IT developers, but you may want to look at that and try to drive your technology developers in the right direction if they're not already there. But I would encourage you to start with clinicians, because we are clinicians on this call, most of the attendees, but look at the patient-facing part of it too, because you're going to want to know what patients are going to be hearing and what the government and educational movements are to try to empower patients. You can respond better if you know what they're being told. This is one of the graphic on the right is one of the educational outreach that the ONC and the government is pushing to allow patients to know exactly what their rights are. And sometimes we hide behind HIPAA saying it's just like you have to protect the information. And we forget that there is also a part of HIPAA that empowers the patient that they may have access to their own information. Most patients who have access to information find it useful. And if you talk to patients who have complex medical conditions, they're often the ones educating the multiple specialists they see about their overall health and coordination. But many patients across the country are not aware of their rights to access, but that's changing, and there's movements to educate families and patients about this. 23% in this recent study didn't even know that they had the right to an electronic copy of their medical record, and we're going to get into that. And 41% of Americans have never seen their healthcare information, which, if we expect patients to be a true participant in their own health and well-being, we have to give them their information. So what do you all need to know? This is a federal regulation that applies to all clinicians. So you can't say, well, I didn't take meaningful use money, so this doesn't apply to me. I don't take Medicare or Medicaid patients or CHIP patients, this doesn't apply to me. If you see patients, treat clinical, treat them with clinical care, and you have information about them somewhere in your office in order to perform that work or bill for that work, this regulation applies to you. And while the regulation was written by the ONC, as we talked about, they're the rulemaking people, it will be enforced by the Office of the Inspector General, but both of them are under HHS. Now, people are worried about penalties for information blocking for clinicians. They're not even written, they're not even draft written, they're not yet finalized. But I will tell you that they are written for health systems and health IT developers, and there are penalties in the millions. And if you think about this sort of when HIPAA started, if you're old enough to remember, we sort of all struggled with what HIPAA was at the beginning. And now it is not uncommon to hear in the news about significant penalties that are that practices, health systems are given if they have breaches in HIPAA and they were not doing their best to protect the information and or they weren't following their own policies. So I really like to think about this similarly to privacy and security parts of HIPAA. And for again, I know that there's practices out there who have not done what they need to do to be compliant for HIPAA. And it's not just when you have a breach. If you are being HIPAA compliant, and that's everyone who practices clinical medicine, not just those who take Medicaid or participate in the old meaningful use program. If you provide care, you are covered by HIPAA, and you should be doing an annual security and privacy audit. And there's two prongs to it. It's the security, am I keeping information secure? And how am I handling the privacy part of it? In my head, this is another additional prong of that work, and that is to make sure that you have information blocking in compliance with the 21st Century Cures Act. Both the HIPAA and the 21st Century Cures Act require us to have policies and procedures to make sure we have identified gaps, have a written plan to address gaps, and then you have to work that plan. Our HIPAA and security annual visit is not, or annual overview and audit is not supposed to be just go through, check a box. It's supposed to be when you find issues, what are you going to do to work to improve, and then make sure that you actually follow up on those improvements. The same thing will apply to the 21st Century Cures Act. The date that matters for us is the April 5th, 2021 date. And you're going to notice this is the timeline, and COVID delayed this. And all of a sudden there's a new term we haven't seen before, which is the applicability date. That's because there's regulations in the law that say that things have to be implemented X months after the law has been finalized. And they gave us all of an extension till April 5th. And that's the new applicability date for information blocking provisions. And we'll talk a little bit about what that means. But you'll notice this moves out into 2023 for certification and the extendability of the information blocking 21st Century Cures. So let's frame this with whose information is it anyway? And clearly research shows that that patients' outcomes are improved if they're involved in their care, and we know that. If there's buy-in in the office, in the exam room, they're more likely for our patients to do what we expect them or agreed to do with them in a shared care plan. But it's difficult to do that if you have limited fragment information. And so again, the 21st Century Cures Act was made to put patient in the control of their information and giving them access to the information. So electronic PHI, which you're used to hearing PHI, it's now EHI, applies to any personal health information that is stored electronically. It might be in your EHR, your practice management system, or any other electronic systems that you have. If the patient or the patient representative requests it in an electronic format, you have to be able to provide it to them in an electronic format. If they say, can you fax my immunization records to my home office, that's okay, that's compliant. They didn't ask for it in an electronic way. But if they ask for it in electronic format, you have to be able to have the ability to provide it to them in that way. You can protect sensitive data in very specific circumstances, and we'll touch on the exceptions in a few slides. But I want you to be sure that you're working to make sure that you're protecting the minimal amount of information. So an example of this might say, you shouldn't say, I can't show you anything on your problem list because I can't hide your treatment for a sexually transmitted infection. You can say, if someone says, please send me my electronic chart, I can't show you your STI problem on the problem list because right now with my current technology, I don't have a way to protect your legal right for privacy for adolescent care and prevent your parents from seeing it. So you can't use a big broad machete to cut people off of their information. We should try to be protecting and withholding information only that's very sensitive and we can justify. You should know that the 21st Century Cures Act does not supersede HIPAA or state regional jurisdictional laws. So think about things like substance use disorder has their own regulations about what data you can share. So does adolescent sexual and reproductive health treatment, but that's different for every jurisdiction. If you don't know what your adolescent privacy jurisdictional laws are, or your substance use disorder laws are, start with your state medical society. And there's a link to the Guttmacher Institute, which has hyperlinks on state level information. But if you're like me and you sort of knew that when you got out of training and you practiced in the same state you trained at, I'd refresh that and to make sure that you're actually following the law. And if you trained in a different place than you are now practicing and you haven't looked at this, there may be actually whispered down the lane misinformation. You want to know exactly what your state regulations are. There are two ways that we are sharing information, and they're both important but distinct. So there is passive sharing of information that many of us are already doing on a portal. And that is giving patients access to their information without having to ask at all. The 21st Century Cures Act specifically looks to responding to requests for sharing of information. And the way a lot of systems are moving this is to put as much in front of the patient and family as you can passively, because if you are drowning from a fire hose of requests for electronic information and it takes you too long to process them, that can be considered information blocking. So April 5th is our date. And information blocking is defined as practices, policies, and actions that restrict authorized access, exchange, or use of electronic health information. So let's start there. Information practices. If you're a health system and you say, we're turning off the portal for every kid over 13 just because, that's a practice. If you have a written policy that says we don't respond or we require an expensive fee by policy to get a patient their electronic health records, that's a policy that may be construed as information blocking. And then there's actions. I took an action that actually limits the patient's ability to have the information that they're entitled to. Inappropriate delays in information release. Well, the person who does this is on vacation or on maternity leave. Like that's someone could report you for information blocking, and you could be at risk. So let's dive a little bit into these three words. Access means the ability or the means necessary to make it available for exchange, use, or both. There, the patient can get at that information that they want. Exchange means that it can be electronically transmitted in a standard electronic format between a different EHR, your HIE, a network, and what have you. So you can not just email a PDF with an attachment, it's actually an electronic information format that others consume, and then there's the use part. Patients and others who ask for information need to be able to use that information, and there is a provision in here that says that they can act on it, which includes the ability to read and write back. And so that you will see over the next couple of years, there is more and more movement for the patients to be able to enter their own data and send it back to you and contribute to a shared record. One of the first steps of that in a lot of places is a patient intake form, but Open Notes is actually a movement where everything is shared with the families, which makes some people nervous. But you may be noticing that the adult health systems in your community are going to Open Notes, and you want to know how they're doing it and what it means for your minor patients. So where do you start? Well, you start by figuring out who's going to own this in your practice. If you don't have someone to own this, you're not going to be able to meet your compliance forward for April 5th and beyond, but you also have to make time for it, and we know nobody's got time to do anything right now. So figure out what that looks like. If it's a team, depending on the size of your office, is it the same person who's your HIPAA privacy and security person? I can tell you that there's not really independent people out there who do this for you yet. I imagine that there's somebody's going to make a business model and hook this onto other third parties who you can hire to help you do this. But I would be wary of people who don't have as much information that is nuanced to pediatrics as you might have access to. And then you got to make your whole practice team, right? It's if you're the person in your office who's attending this, you're going to have to figure out how you make sure that the whole practice team is aware of this, because some of this is going to be shared work. The next thing I would do is really commit to understanding whatever technology you have now, what information you can and cannot protect that's sensitive. Because pediatricians are frightened all across the country. Oh my, I have stuff in my problem list that says, you know, don't talk to dad, he escalates to whatever. If that information is going to be shared, you have reason to be cautious about what's being shared. So you need to understand what is shared with whom. And when people give patients access to information, no matter how they're getting it with requests, you need to understand what's going and how you can protect it. You also want to document, how do patients currently request information? I'm going to see the allergist and I want a copy of my chart, right? How do they currently do that? How do you provide it? Do they have the opportunity to say, I want an electronic copy of my information? And how would you comply with that? Now, there will be a gap here as we move forward where you'll be going to be like, I can't give it to them electronically. And that's okay if you document the patient requested it that way and you don't currently have the ability, and the two of the family and you decide what's a reasonable alternative now. But in your policy and procedure for 21st century cures information blocking, you should have a written out plan on, I have a gap now in that I can't give my patients electronic information. What's my plan over the next months and years to make that more robust? I would start tomorrow documenting all of your information in a way that starts to allow you to feel more confident in the sharing of the information. Because you know this information is now going other places, and you will not have a chance to clean up the chart before you release the records. They're likely being shared and you're not even aware of what's being shared. You and your practice team really need to start saying, in my current technology, how can I protect sensitive information correctly? And then every time you touch a chart, you want to clean it up for accuracy, including meaningful start and end dates to problems and meds. If you have 72 documented problem list items of well child, and you send that to me electronically, I'm going to be like, okay, why didn't you clean up your own electronic EHI before you send it to me? Because now I have to deal with it. So we want to really make sure that both the patient and whoever they share with it get meaningful benefit out of the information. And that's only going to happen if we are consciously cleaning up charts, daily dusting, data dusting, as I like to say, and protecting sensitive information to our ability. There is a difference in systems and how they behave. Some systems will allow you, when you're writing the information, to protect it. Others say before you share it, there's a redaction function. You need to know how that works for your technology and make sure that it's working for you. So as we talked about this at the AAP with the Council on Clinical Information IT, we talked about some guiding principles and some examples. And realistically, if we're talking about empowering all of our patients with information, we should be making clinical information as available as possible while we're being certain to respect legal limitations. Most of us will be accomplishing at least some of this through a patient portal. And if you don't have one, that's not your only option, but there has to be an electronic method of sharing. It could be an API. There's something called FHIR standards, which people are using for electronic access. But if the only way you currently can share information with families is fax, encrypted email, paper charts, PDFs, CD-ROMs, thumb drives. That doesn't meet the spirit of the 21st Century Cures Act. And you and your practice team should sit down and say, okay, that's a huge gap. What's our plan to close it? What are our options? When we talk about sharing of information on the portal, if we were going to do this ideally, parents and proxies would have access to their child's non-sensitive information, right? I want to give them everything to manage the child's diabetes, but not their private conversation they had with me about birth control. Adolescents should have access to their information, including sensitive information. Some states say if you're a minor, you need parental consent to get to your own adolescent information. Make sure you know your rules, your laws of your jurisdiction. And until we can get there, and we have supported technology, what are alternative ways to release information safely? So you can say to that teen, you know, I'm sorry that I can't protect this information, so you can't have access to it electronically. Let's talk about how you can manage it. The other thing that you should understand is even if you can protect it safely, what happens if you send it to someone else and they reshare it? If the receiver can't protect it, you have potentially put that sensitive information at risk for redisclosure. So again, empowered patients, people say it's our record, our right, our choice. You should be aware of what other health systems around you, because if you are feeling like, yeah, my patients don't need this, but the parents are going to a health system and they have access to it, they're going to turn around and expect it and say, why don't I have the same technology for my kids that I do for myself? And on April 5th, they could file a complaint that you are information blocking. Again, we don't have any penalties. That whole part of it is not written out yet, but it's coming. So you should not ignore this and pretend it's going to go away. You should know where you are and where you need to go. One of the goals is to allow patients access to the records so they can give information to the specialist of their choice, or transfer their records from one PCP to another without even asking for them. So I want to pause here. I had a patient transfer to us who on their portal at their health system, they were allowed to download my patient notes and send them to me via secure direct messaging with a CDA attachment of every time they were seen. So this was a mom who didn't want to pay the requested records transfer, and she said, I'm taking it electronically myself. I have my right, it's my right. You're going to see more like that, which means that we have to do a good job of making sure that we are adding value to our medical home so that our families really want to stay with us. But know that that's out there and it's already starting to happen. Let's talk about exceptions, because everybody wants to go to exceptions, and I'm going to tell you that there's going to be more information from the Pediatric Success Series coming your way, where I'll dive a little bit deeper into exceptions, and the AAP is still trying to get pediatric clarity on some of these. But there are 8 ways that you can say, I can't give the family requested electronic information, and I can't give it to them, or I'm choosing not to. One of them is the preventing harm exception. And when pushed, the ONC said, yeah, every physician thinks that the patient's gonna get harmed if they see what I wrote in their records. That's not good enough. We all have concerns as pediatricians that a preventing harm exception might be if a parent finds out that the child confided to us that they are transgender or exploring their gender identity, and that could cause harm. And so the Academy is working with the ONC to talk about the mental and emotional and physical harm that could happen with sharing information for minors, but that's yet to come, and more of that will come. If you can't do this securely or respect privacy, you can use those exceptions, and we'll talk about them more in in future presentations, but you better be working to figure out how you can do it privately and securely. Then there's the infeasibility exception. I just don't have the feasibility with my current electronic health record to protect individual problem list items. And so I can't honor this patient's request to get their chart electronically. So it's infeasible for now, but here's what I'm doing to work with my technology to make sure that I'm getting there. And so we'll get into more details in a future, but I wanted you to see them and you can explore, and there's resources at the end of the presentation to learn more. So let's talk about what must be shared if you want to avoid someone accusing you of information blocking. So until October 6th, that's of 2022, for the purposes of information blocking, the electronic health information that you must share electronically is in accordance with data elements that are represented in something called the US Core Data for Interoperability Standard. Okay, part of the final rule for 21st Century Cures is that we're going to use this US CDI version 1 standard, and all of that information, all certified technology has to be able to give to you electronically and share electronically. Clearly, technology for many vendors is advancing and not completely there, but is working towards that. But after October, it even gets to be broader. And I want people to understand that we can not only have empowered patients, we can be empowered pediatricians. Because of this 21st Century Cures Act, health systems or organizations can no longer refuse or make it impossible for us to get electronic data on our shared patients, or we can call in for ablation blocking on them. Starting in April, we can file a grievance with the Office of the Inspector General. For example, if you have a large regional system that says, yeah, we're not sending you consult notes or admits discharges and transfers because we're trying to own you and compete with you, or you send all of your patients to the competing healthcare system, yeah, no, they can't get away with that anymore. And so you will be able to say, set me up in your interface, your HIE, your lab, or I'm going to call information blocking and file a grievance. And so this is really empowering for some of us who have been sort of shoved to the margins of some of the technology exchange with the big vendors. And that actually is a great opportunity for us to improve data exchange and care. The other thing that we should really think about, and what I want you to think about, and if you've never seen a CDA or CDA reconciliation, please click through the links in the resources so you can do it. But we spend an enormous amount of time hand transcribing information we get from others about our patients. Every transition to care, add to the problem list, type in the meds, add the labs, make notes about stuff. If we do this through the CDA, which is an electronic standard, or an app through FHIR, every certified technology system has to be able to consume that, and you should be able to say, in a couple of screens, here's what I have on my problem list electronically, here's what the outside report says, I want to add this to my problem list, yeah, I want to ignore that, that's a duplicate of mine, just said differently, etc. Which, if we can get there, really, really will reduce the burden of hand transcribing a bunch of faxed pages that we're trying to read out of a document. But remember, if the sender's electronic health information is messy and cluttered in their EHR, you're going to get equally messy and cluttered information when you receive it. And we already hate the 30-page EHR documents. We have to be good stewards of our patients' information, and that means you need to really look at your notes and your problem lists and your meds and make sure that you have good practices for all your practice team members to clean them up, because other people are seeing your messy bedroom. Okay, this is too small to see, but there's a link in the title there that takes you there. This is the current information that is in the US CDI version 1 data set that is part of a CDA, and everybody should be able to share electronically. So I want to point out a couple of wins for pediatricians. We finally got a head circumference in here. It took us forever, but it's there, which is incredible. And we're working to address it. But all of our notes, history and physical, consultation notes, all of that stuff is in there. Care team members, who's part of the care team, all of that is in there. And I encourage you to really look. These are, when you go to the ONC site or the Health IT site for this, all of those top levels, anything that's blue is hyperlinkable, so you can dive deeper and see exactly what needs to be shared. And whoever you are using to store and exchange your electronic health record information, you should make sure all of this is supported in that work. So version 2, remember I said beyond October of 22, this is getting bigger. It is, and a couple of things I want to point out to you, we already talked about. The problem list now has date of diagnosis and date of resolution. If you don't have the capability to put start dates and stop dates on your problems, find out how you could be able to do it with your technology. If it's there and you just don't do it, your friends and colleagues are going to be drinking from the fire hose of ugly information. We're adding that because you should be able to see which are the current problems for the patient and which ones are resolved. And if it's all intermingled, you know, it's really hard to get that information. Okay, so now that everybody's worried about being called out for information blocking, what not to worry about. You don't have to worry that April 5th, someone's going to report you for information blocking and you'll be fined millions of dollars, right? Or that everything has to be in place and perfect by April 5th. That is not going to happen. They are not going to, now, by the way, when you do HIPAA, not only is it if there's a breach that they come and ask you for information, there are a subset of all practices that get through a federal mandate get audited every year. So even if you did everything right and somebody came to you and says, sort of like, you know, getting your taxes audited, your numbers up, show me your policy and procedure and your security and privacy audit that you did last year. If you don't have it, you can be fined for not having it. That's not going to happen here April 5th, but expect, just like HIPAA, that's where this is moving. So get in early. Please get your heads out of the sand, and your practices who say, my patients don't want a portal, they don't want access to their information, this doesn't apply to me. Get your head in the game and make small incremental movements towards success. Oh, one other thing. It is not your information you put in your EHR from April 5th forward. This retrospectively applies to all information you already have stored. So there may be some provisions you need to clean up data converted, ugly, messy information, or you never use the security privacy features of either your EHR or your portal. Now's the time to talk about this, and it's not just going forward. You could say in your policy and procedure, like, we got a lot of ugly stuff we have to clean up because we don't think it's safe to release. So we're only releasing information from X day forward when we've been good about it since we listened to Sue's webinar. But our process is going to be spending the next 6 months cleaning up old information so everything is shared as broadly as possible. They are also not going to come on April 5th and look back and say, in December, a patient requested an electronic chart and you didn't give it to them. That will go forward. But the information you collected, it's everything you have. So how are pediatricians helping these efforts? Well, the Council on Clinical IT is in constant contact with the ONC to get pediatric clarification, and I will share this more broadly as this becomes clear. There is a national work group that actually started at the Academy by a bunch of people on the Council on Clinical IT, led by Joe Schneider, who kept saying, we have to figure out how to protect minor and adolescent sensitive information before all of the can of worms gets open, and now we're having to share information we don't know how to protect. This has grown out of an academy work led by Dr. Hannah Galvin, myself, and a few others, to a national multi-stakeholder group, including EHR vendors, privacy people, legal people, ONC, HHS people, patient advocate work groups that were really trying to move the needle. It's called Protecting Privacy to Promote Interoperability. And if you want to know what we're up to, Jess Hackle, if you happen to know him, who's on COPAM for the AP, myself, Hannah Galvin, happy to let you know what we're up to. And if we need help, we may be reaching out to you. We need pediatricians to help define workflows for your organization, which means that if they've just decided we don't know how to protect this granularly, so we're just letting everyone see everything, you have to say, stop, let's have a conversation here and lean in, don't wait for someone else to do it. Similarly, if you have technology vendors who haven't figured this out, you need to move them in the right direction so that we can all do this safely. There is the ability to comment on that second proposed data set. So if you think it's ridiculous that we have to put start and stop dates on our problem list or other things, anybody can comment, go look at that draft, publicly make your comments known so that you can influence where this is headed in the version 2, and there's probably more to follow. Lots of resources available. Suzanne Berman, my dear friend and colleague, shared this information with SOPAM, and she was kind enough to share it here. She sort of made an information blocking guide for dummies. It's a Dropbox link if you click on there, so understand you're going to need to download a Dropbox. She put a disclaimer on there saying this is her best interpretation, but I do believe that that's a great place to start about what to be worried about and what to just work towards. And the first link is the ONC information blocking frequently asked questions. That is being updated. They just added a new set. I would start there if you have questions to make sure that you're being addressed by the ONC. There is no comment yet about what's going to happen with penalties. The clinician part of it has not even been drafted, but I will share more broadly with all of my pediatric colleagues. Once we get to a draft for that, use your voice and use the public comment period to say what you think is fair and not fair. Okay, with that, we're going to move to questions. And Carrie, I think that you're poised to help me here.
Yes, for sure. But before we do that, I just wanted to quickly address a few housekeeping items. In the next 48 hours, all of attendees of today's live webinar will receive an email with a copy of the presentation, the webinar recording, and the CEU certificate. Also, when you close out of today's event, you'll receive a brief survey. Please take a minute to provide your feedback. We are planning a follow-up webinar to this one, and we want to make sure that it meets your needs with regards to the 21st Century Cures Act. And also, as part of the survey, you'll be able to request follow-up from an OP representative regarding OP products and services and how the company is helping their clients move through the 21st Century Cures Act. Okay, so with that said.
So I just wanted to let everyone know what's OP doing, because I know that some people on the call are OP practices. We're really fortunate because from user one, which was Edna Pitlack, and day one, OP has always allowed pediatricians to granularly protect sensitive information, including problem list items, medications, lab results, notes, parts of notes, survey results. And so we will be doing a lot of education so that people know exactly how they have a lot of power to make sure they're using it. And we'll also be talking about how you can clean up some of your data that probably you didn't protect and now you wish you did. And we're also going to be engaging our community pediatricians on best practices. How do you use tools that you have, both OP, our patient portal through IntelliChart, and direct messaging in order to be compliant or move towards it if you don't have all of that functionality today.
Wonderful.
All right.
Thank you very much.
Do we have any questions?
Yes. Yes, we have many. So let's go ahead and just jump right on in. The first question is, how can we know at what age we can give information to a teenager?
That is state and jurisdictionally mandated, and so I would check with either your AAP chapter or your state medical society often has those things about when you can, and there are some states where you have to have the parent permission to share with the teenager. And so I wish I had one size fits all, but ask the question now so that you know.
Perfect. Great advice. Another question is, when a practice closes because someone is retired, will they still be required to comply with this, or can they just provide previous records by fax? And in this example, it was a solo practitioner who had retired.
So because you no longer have access to the technology, that's your infeasibility exception. I would still write a policy saying I'm retired, the practice was retired, those records were not made available, and the technology at the time of the closing of the practice did not have the ability to. So we will be, and about how you will still be giving patients access to their information, but it's unfeasible to do it through an electronic means because the data is not, maintained in a technologically possible platform.
Perfect. Thank you very much. And another question is there a time frame required to respond to requests?
That's a very interesting question, and the ONC is publishing on their frequently asked questions some sort of time frames, but they've been a little hesitant to do that. I would say that, a month, yeah, no way. A day, maybe not. And again, there's a difference between requesting it versus passively making it available for families so they can do it. And a great example of this is lab results. People say, I want to be able to review my lab results before I make them available to the patients. If you write a policy statement about why you think that as a broad share is a good policy, you might be okay, but I would argue some people might say that's information blocking. If you said there's certain labs like pregnancy tests or HIV results that require more granular protection, and someone said to you, how come you didn't give me all of my labs, including my pregnancy test electronically, you'd probably be more justified because you say that you've granularly protected that information because that should be protected. That being said, I think that we have to get away from feeling maternalistic and paternalistic about data. The families are getting notified when the labs are posted and they have a Quest account, or a LabCorp account. We can no longer say it takes us a week in our practice to process lab results. We have to figure out when we order lab results, have a policy and procedure that says, in our office, throat cultures, if they're negative, we post on your portal. If they impact care decisions, we call you within, 48 hours of receiving them, and then just make sure that you're monitoring your compliance with your own records. But there was an interesting question on the SOPM listserv recently about, I have a partner who doesn't like to look at the labs over the weekend when they're on call. If a family said, you had those labs, it would have changed care. My kid got sicker because they were on the wrong antibiotic for a UTI, and you had that information 3 days before and didn't release it to me, that's going to be problematic for you medical legally and potentially information blocking. So you need to look at those policies and make sure that you're following your own procedures. And I will just tell you that if you set the right expectation, if it's a lipid panel, you can say to families, I'm sending you for a lipid. There is nothing that's going to be emergent about this lipid panel. We will get back to you within 3 business days of receiving your lipid panel. Don't panic if you see some weird numbers. If you're getting a CBC, say, if this is emergent, the lab calls us and faxes us with urgent results. We will get back to you the same day with that. You're going to see an RDW that looks weird. That's normal for kids. Don't panic. If you can see those results before I do, I promise we'll get back to you in 2 days. If you have any questions, shoot us a portal message, whatever. But we can no longer say it's our information that the patient is begging us to see. It's their information that we are sharing together so that they can get the best outcomes. Next question.
Okay. How does this work in separated parents and their child's chart? I have several families that are in the he said, she said stage, but I worry about mom's safety if dad becomes aware of the things mom is telling me, but I feel like I need to document this in the chart so that I can provide the best treatment for the patient.
So first of all, not everybody's technology works the same, and so you're going to have to know what that looks like. Let's start with what you're documenting in your medical record. Find out if there's a place in your medical record that you can keep that kind of information so it is not more broadly shareable to anyone who is a patient proxy. Then you want to find out on if you have a portal or if you're sending electronic information, when dad requests, is there an ability to filter? Dad only gets dad's information and about the kid, any messages, and mom only gets hers. Most don't work that way. A proxy is a proxy, and everybody has access to the same information, and that includes teen proxies, or teens of their own count, and their parents. So first of all, you need to figure out, how do you protect and document today what you can protect? And then how does your sharing or redacting, some people mark it at the time that they've documented, and it just doesn't go if you put it in a certain field. And some places it's before it's shared, you have to take an action to take that information out. But that means that you then have to be careful about how fast you can process all that stuff and remember what you wrote. So it's an interesting conundrum, but this is one of your gap analysis that you should see in both how you can document and protect that information. But you should assume, until proven other ways, that even messages and shared information about the child is shared equally to anyone who's responsible and has legal ability to get that information.
Okay,
next question. Yep.
Yeah, so we have several folks who had said, how does this requirement impact practices that still have paper records?
Interesting, it still does, because I bet you have a practice management system you're using for billing that has ICD diagnoses and CPT. That's medical work. So you have to figure out whatever you have electronically, you can share electronically. If the family wants to know a list of all my problems and visits, diagnoses, and CPTs, how do you provide it to them electronically?
Wonderful, thank you. And this is around the patient portal. Says that we are still experiencing lots of resistance to our patient portal. Any thoughts on making it a requirement for patients to use that?
So let's start with what the 21st Century Cures Act says, right? The 21st Century Cures Act says if they request it electronically, you have to give it to them electronically. And so if they don't ask for it electronically, then they can't report you for information blocking because they weren't using the technology. If they call you up and say, I want an electronic copy of my records because I saw that thing on healthit.gov, you can say, well, the way that our practice supports that request and technology is through a portal. How can I help you sign up? But I do agree it is cumbersome to try to live in two worlds where some patients are using the portal and some are not, because you're trying to figure out how do you solve the problem in two different ways in two different workflows. My answer is find a win for them. What is it? What is the value for them? Is there something that would be valuable for them to be able to do through a portal? And the only way you're going to know that is to ask families, and maybe you get a virtual focus group of people who say that and walk you through things. It's very interesting, especially with COVID-19 vaccines. Everybody has this presumption that old people can't figure out how to self-register and whatever. There's some ageism that goes in on the other end of life, and I feel like in pediatrics we get the other piece of it, that if shown the value on how to, more people will be able to do it than not. Bob Stevens, our colleague in Texas, who's got mostly Medicaid patients and a lot who are not native English speakers, has found value in the portal. In my practice, when we started, we made new patients register on the portal so they understood there was a technology experience that's part of that, and we're looking to transition that to the new portal. So there's no right answer, but talk to your colleagues. Other people are having the same challenges, and build on their successes. Don't reinvent the wheel. But I think the biggest answer is what's in it for them. Everybody wants to know what the WIFM is. Like, what do they get out of it if they use it? And it's empowering.
All right. Thank you. Unfortunately, we are nearing the top of the hour, so this will have to be our last question, but I just wanted to remind all attendees that we'll be compiling the questions that we were unable to address, and we'll be sharing the answers to those with you via email. So our last question is, does this mean our office can no longer charge for personal copies of medical records once this becomes effective?
So that's a very interesting question, and this is different for states, and there's different state maximums, and it may be that your practice can charge if the patient wants a paper record, because that's harder to process, but you can't create a fee for self-service of downloading an electronic record and sending it somewhere else. So as more patients are going to be asking for or taking their own information without asking, you have to rethink those transfer of care and what that looks like, and the request for records.
Okay. Well, thank you so much, Dr. Kressley, for sharing your expertise with us. And we also wanted to thank all of you for attending today's webinar. Don't forget to take the brief survey when you leave so we can have our follow-up webinar and make sure it meets your needs. And everybody have a great day. Thanks.
And please stay safe. Keep fighting the good fight. Give good care to kids, and try to keep yourself safe. Every day you go to work, you impact lives, and it really matters. Thank you.
Thank you.